Hi everyone. We are Group 9, and the group members are Angela Alcover, Chris Lim, and Andre John Ngo. And we will be talking about mood disorders. So, for our reporting, we will be tackling about the etiology, the prevalence of incidents, the signs and symptoms and pathomechanics, as well as the types, the course, and the prognosis. We will be also tackling about the management and the existing support system in the country, as well as the speech, language, hearing, and or swallowing problems that may arise to individuals with mood disorders. Let's define first what are mood disorders. So, a mood disorder is a mental health problem that primarily affects a person's emotional state. So, it is a disorder in which a person experiences long periods of extreme happiness, extreme sadness, or both. So, mood disorders can change an individual's behavior and can affect their ability to deal with routine activities such as work or school. There are two common mood disorders, and these are depression and bipolar disorder. As we all know, depression is a common mental disorder. So, grief or sadness is a typical response to a traumatic life event. However, when the depression continues to be present, even when stressful events are over or there is no apparent cause, physicians will then classify the depression as clinical or major depression. On the other hand, bipolar disorder is also called as manic depressive disorder, is defined by the extreme shift in mood from periods of depression to mania. So it is a mental illness that brings severe high and low moods and changes in sleep, energy, thinking, and behavior. So let's now proceed to the etiology. So there are several underlying factors depending on the type of disorder. So various genetic, biological, environmental, and other factors have been associated with mood disorders. So these risk factors include family history, imbalance of brain chemicals, previous diagnosis of a mood disorder, trauma, stress, or major life changes in the case of depression, physical illness, or use of certain medications as depression has been linked to major diseases such as cancer, diabetes, Parkinson's disease, and heart disease. And lastly, the brain structure and function in the case of bipolar disorder. So, for bipolar disorders, studies have shown that biological or genetic factors might be a cause to develop bipolar disorder. There is no specific gene that can really cause the disorder, and most people with a family history of bipolar disorder will not really develop the illness. So, in cases such as having twins in the family, researchers have shown that only often one twin gets diagnosed with the disorder. On the other hand, biochemical factors might also cause bipolar disorder, for there are studies that mentioned and noticed that individuals that have experienced a manic episode have had increased levels of norepinephrine, which is responsible for our response to stress or anxiety, and dopamine, which is our feel good neurotransmitters and responsible for our response to pleasure or happiness. Studies have also shown that brain structure and formation of individuals with bipolar disorder are different in the right-sided lesions in the limbic system, the temporobasal areas, the basal ganglia, and thalamus are shown to induce or influence secondary mania. And lastly, other studies have shown that there are certain medications used to treat somatic illnesses that have been known to trigger a manic response. Specifically, the most common are steroids that are frequently used to treat chronic illnesses. So these medications results to bipolar disorders. So let's proceed to the different risk factors for depression, and these are the chemistry of the brain, or the different factors, I mean, includes the chemistry of the brain, which involves the different neurotransmitters that affects the neurocircuits involved in maintaining mood stability that might cause or affect depression. Other would be hormones, especially for pregnant women, which goes through postpartum depressions. Age would also be a factor, especially for older people that are living alone and have lost important people in their lives. Studies have shown that gender as well might be a factor, for it was shown that women are more likely to become depressed than men. Studies are not sure why, but others have said that it might be due to hormonal changes that women go through at different times in their lives that leads to depression. Other risk factors also includes the genes as well as substance abuse, the personal problems, and major changes in life. Let's now proceed to the prevalence of incidence of depression. We know that the mental illness is the third most common disability in the Philippines. So there are around 6 million Filipinos that are estimated to live with depression, making the Philippines the country with the third highest rate of mental health problems in the Western Pacific region. But at a global level, there are over 300 million people that are estimated to suffer from depression, and it is equivalent to 4.4% of the world's population. And there are 1 in 10 Filipino young adults that experiences moderate to severe depression, with a total of 1,145,871 identified cases, and the prevalence of moderate to severe depression in Filipino young adults is higher among females than males, with a ratio of 1.2% in females and 1.1% in males. For the prevalence of incidence of bipolar disorder, according to the World Health Organization in an assessment done last March 2020 in the Philippines, there are a total of 500,614 identified cases of bipolar disorder with a gender ratio of 0.2% in females and 0.5% in males. So let's now talk about the signs and symptoms and the pathomechanics of depression. So, in order for a person to be diagnosed with a mood disorder, symptoms must be present for several weeks or longer. As there are different types of depression, symptoms may vary depending on the form of the disorder. So, the signs and symptoms of major depression is that individuals feel sad most of the time or nearly every day. They also lack in energy or they feel sluggish, and they also feel worthless or hopeless, and they also have or lose their appetite, or sometimes they overeat. They also have low self esteem, they have excessive guilt, and they are sensitive to failure or rejection. They're also irritable, hostile, and aggressive. Some individuals gain weight, and some also lose weight. And most of them also have a loss of interest in activities that formerly brought enjoyment to them. They also sleep too much, or sometimes they do not sleep at all, or they have a hard time sleeping. And there are frequent thoughts about death or suicide, and they really have a difficulty concentrating or focusing. So let's now proceed to the pathomechanics for major depression. So the underlying pathophysiology of major depressive disorder has not been clearly defined, but there are current evidences that points to a complex interaction between neurotransmitter availability and receptor regulation and sensitivity underlying the affective symptoms. So the neurotransmitters implicated in depression are the dopamine, the norepinephrine, and serotonin. And there are main subcortical limbic brain regions implicated in depression. And these are amygdala, the hippocampus, and the dorsomedial thalamus. Thus, both structural and functional abnormalities in these areas have been found in depression. So let's now proceed to the signs and symptoms of bipolar disorder. I would just like to take note that it may include both depression and mania. So the signs and symptoms of bipolar disorder is that the individuals feel extremely energized or elated. They also have a rapid speech or movement. Agitation is also present, restlessness as well, and they are also irritable. They also have a risk-taking behavior, such as spending too much money or driving recklessly. There is also an unusual increase in activity or trying to do many things at once. And they really have a lot of racing thoughts, and they really have trouble sleeping, or what we call insomnia, and they feel jumpy or on edge for no apparent reason. So let's now talk about the pathomechanics for bipolar disorder. So individuals with bipolar disorder exhibited thinner cortical gray matter in frontal, temporal, and parietal regions of both brain hemispheres. So it is also due to the changes in the level rather of brain neurotransmitters. So the behavioral and psychological manifestations of bipolar disorder are complex and undoubtedly mediated by a chain of interconnected neural circuits.
Next, we are going to talk about the types of depression. So there are 6 types of depression that we are going to be discussing today. The first one is a typical depression. So this is a type of depression that does not follow what was thought to be the typical presentation of the disorder. This is usually the hardest to diagnose as it does not show the typical signs and symptoms. That is why in the signs and symptoms presented, it could either be oversleeping or undersleeping or overeating or undereating, because it could really manifest in different ways. Next, we have psychotic depression. So this is a type of severe depression combined with psychotic episodes such as hallucinations or delusions. The episodes may be very upsetting or disturbing and often have a theme. Next, we have situational depression. This isn't exactly a technical term that psychiatrists use, but you can have a depressed mood when you're having trouble managing a stressful event in your life, such as a death in your family, a divorce, losing your job, and your doctor may call this stress response syndrome. Psychotherapy can often help you get through a period of depression that is related to a stressful situation. Next, we have postpartum depression. So this is a form of depression that occurs during pregnancy or after delivery. This may be due to all the hormones released during pregnancy and the imbalance of the hormones, which causes the mother to experience intense depressive moods that could affect how she cares for her baby and feels towards pregnancy and babies in general. This depends on mother to mother and could last for a short period of time or 1 to 2 years. Next, we have seasonal affective disorder. This is a type of depression that occurs during certain seasons of the year. It could start from late autumn to winter and last to spring and summer. So this is usually for people who live in countries that have 4 seasons. As the season becomes gloomier and dark, it affects their mood in general and cause this type of disorder. Lastly, we have depression related to medical condition, medication, or substance abuse. So like mentioned in the etiologies, these factors could be a cause of depression. Cancer is one of the medical conditions that could lead to depression, as it will affect the person's ability to do day-to-day activities and inhibits the person from participating in his normal routines. Next, I'm going to talk about the course of depression. So depression first begins as a major depressive disorder, also known as clinical depression. It is diagnosed when someone experiences at least one major depressive episode in which they suffer from a depressive mood and loss of interest or pleasure in nearly all activities for at least 2 weeks. In addition, depressive symptoms must persist for most of the day, nearly every day, and cause problems in social interactions, work, or someone's ability to function in daily life. Major depressive episodes can last up to 4 months and become more frequent if not addressed. If a major depression persists for more than 2 years, it is considered a persistent depressive disorder, which is a chronic form of depression, also known as dysthymia. Next, we have 4 types of bipolar disorder. First, we have bipolar type 1, so it is the most severe form of bipolar disorder. Manic episodes last at least 7 days and may be severe enough to require hospitalization. Depressive episodes can also occur together with the manic episodes and last for at least 2 weeks. Next, we have bipolar type 2. This disorder causes cycles of depression similar to those of bipolar 1. A person with this illness also experiences hypomania, which is a less severe form of mania. Hypomania periods are not as intense or disruptive as manic episodes. Someone with bipolar 2 disorder is usually able to handle daily responsibilities and does not require hospitalization. Third, we have cyclothymia disorder. This type of bipolar disorder has sometimes been defined as a milder form of bipolar disorder. People with cyclothymia experience continuous irregular mood swings from mild to moderate emotional highs to mild to moderate lows for extended periods of time. Additionally, changes in mood can occur quickly at any time. There are short periods of normal mood. For an adult to be diagnosed with this disorder, symptoms must be experienced for at least 2 years and at least 1 year for children. The last bipolar disorder type is other or unspecified bipolar disorder. The symptoms of this bipolar disorder do not meet the criteria for one of the other types, but people still experience significant abnormal changes in mood. Lastly, we have 2 other mood disorders. So our report mainly focuses on the 2 main disorders, which is depression and bipolar disorder, but there are other 2 mood disorders worth mentioning. First, we have the premenstrual dysphoric disorder. This is a type of mood disorder that occurs 7 to 10 days before menstruation and goes away within a few days at the start of the menstrual period. Researchers believe that this disorder is brought about the hormonal changes related to the menstrual cycle. So we would think that this symptoms would be similar to PMS, and it is, but it is a more severe type. Second, we have Intermittent Explosive Disorder. This is a lesser-known mood disorder marked by episodes of unwarranted anger. It is commonly referred to as flying into a rage for no reason. Their behavioral outbursts are out of proportion to the situation. The most common management or medical treatment for mood disorders is medication. There are many different medications available to treat depression and bipolar disorder. So first we have antidepressants, specifically selective serotonin reuptake inhibitors. So the ingredients of this medication can be found in our written report. But many different types of antidepressants are found to work well, and some antidepressants may be more effective depending on the individual. So each different patient will have a different response to this certain medication. It is important to take antidepressants as prescribed and continue taking them even when you feel better. Next, we have mood stabilizers. These medications help regulate mood swings that occur with bipolar disorder and other disorders. They help reduce abnormal brain activity. Lastly, we have antipsychotics. So this is used to treat patients with bipolar disorder and may sometimes be used to treat depression if symptoms are not controlled with an antidepressant. Together with medication, therapy is also highly prescribed to these patients. First type of therapy is psychotherapy. Patients with depression and other mood disorders may benefit from various types of psychotherapy or counseling sessions. These types include cognitive behavioral therapy, impressional therapy, interpersonal therapy, and problem-solving therapy. Next, we have brain stimulation therapies. This therapy works by causing changes in the chemicals of the brain that are known to be associated with symptoms of depression and bipolar disorders. There are several types of brain stimulation, including the following. First, we have electroconvulsive therapy, or ECT. Electrodes are placed in certain locations of the scalp or forehead. An electric impulse is passed to the brain to induce a seizure. Second, we have repetitive transcranial magnetic stimulation, or RTMS. This is a non-invasive procedure which uses magnetic coil to apply short electromagnetic pulses to specific nerves in the brain. This procedure is used to treat major depression for patients who do not respond to at least one antidepressant drug. Next, we have the management team. So first we have the doctor, a primary care physician who provides comprehensive care to patients with mood disorders by diagnosing and treating them with the psychiatric disorder and psychiatric comorbidities, providing medical care and educating and supporting patients and their families. Next, we have nurses. So nurses treat patients with mood disorders by assessing them, monitoring the clinical progress, enhancing the treatment compliance, promoting social change and education of the parent and the caregivers. Next, we have pharmacists. So they play an important role in the promotion of the importance of medication adherence and educating patients about how to recognize triggers for their mood episodes. Pharmacists use motivational interviewing techniques to help patients become comfortable with their diagnosis, educate them to take responsibility for them managing their condition, reviewing optimal administration times, potential side effects with patients, and will help pharmacists improve adherence in patients and reduce the number of hospital visits. Neurologists play a role in the diagnosis and treatment of mood disorders. They predict the neurological signs and symptoms that may determine the presence of a mood disorder or the type of mood disorder. Next, we have the psychiatrist. So it is a doctor that specializes in physical brain and its interaction with behavior to create the patient's personality. Psychiatrists will determine whether the illness is caused by mental health or another physical condition. They often look to rule out another medical cause of the symptoms before a diagnosis. They also consider whether a chemical imbalance is causing the problem, as well as observe the physical reaction of the body to the symptoms. Psychiatrists also study the effects of medication on the body. After diagnosis, they might prescribe medication to manage the condition. Next, you have psychologists. So they identify mental health conditions. They focus on the patient's thoughts and emotional state. They provide treatment for mental disorders. They can also provide counseling and psychotherapy. We have a psychiatric nurse. So they help to improve and support the mental and physical well-being of the people with mental health or behavioral conditions. Lastly, we have speech-language pathologists. So they address communication and swallowing impairments that may co-occur with depression or bipolar disorder, or other mood disorders. In the same way, sometimes adults and children with speech and language impairments may develop depression. Next, I'm going to talk about medical precautions that SLPs should be aware of. First, we're going to talk about motivation. So SLPs should take note of the patient's motivation in therapy. The SLP should make sure that the patient is in proper disposition to ensure that the therapy goes well and that the session will be productive and that the client will get the quality therapy that he or she deserves. Next, we have mood changes. So because they have mood disorders, their mood will definitely change and may affect their cooperation or motivation to participate in therapy. So the mood changes may affect the productivity of the therapy sessions. Lastly, we have sensitivity. SLPs should be more cautious about how they interact with these patients, like with the words they use, the concepts, and scenarios that they provide as examples for the activities. They should be able to ask the appropriate questions and avoid invading their privacy and be sensitive to their patient's history.
Now for the existing support system in the country. So we have the Mental Health Act, or the Republic Act number 11036. So basically, this act seeks to establish access to comprehensive and integrated mental health services while protecting the rights of people with mental disorders and with the family members. We also have mental health support groups present in the country. So basically, mental health support groups, they provide an opportunity for people to share personal experiences, feelings, coping strategies, or first-hand information about the disease or treatment. So the list of mental health group supports actually goes on and on, because there are a lot of mental health groups in the Philippines that are present and available. And the following are just some of the many support groups that have been established. So we have the Philippine Mental Health Association, the Anxiety and Depression Support Philippines, Be Healed Foundation, Buhay Movement, and many more. So the list, you can find the list in the links that we have provided in our report. We also have the Psychological Association of the Philippines. So this created a list of centers offering free online psychological services during the COVID-19 pandemic. Then we have the Mental Health National Hotline. So the numbers can be found in the site that we also provided. And lastly, we have the Silakbo. So this is a website dedicated to the promotion and awareness of mental health. Next, we will talk about the speech, language, hearing, and or swallowing problems that may arise with these mood disorders. So first, for speech, so studies have shown that individuals who are diagnosed with depression result in having their speech become more monotonous, more slow, it's more labored and has more stops, pauses, and starts. So in worst cases, depression leads to a more hoarse voice and less fluent speech. In terms of language, so communication problems, socializing, expressing emotions and feelings. So developmental language disorders have been found to contribute to the development of personality disorders in adulthood. So incidence of post-stroke aphasia patients with depression is more than 50%. In hearing, it makes intuitive sense that a connection exists between hearing loss and depression. So when people struggle to hear, communication becomes challenging, and loneliness, sorrow, and social isolation can quickly follow. So those, according to Wind, he says that those who are hearing impaired may also be sending weaker auditory signals to our brains, which means that our brain has to work harder to process sounds, resulting in a loss in function in other processes such as our memory. Our neural pathways may reorganize, causing our brain to change the way they function, including the areas that regulate depressive symptoms. And lastly, for swallowing or feeding, so dysphagia is reported to be caused by the adverse effects of antipsychotic medications, factors associated with institutionalization such as dependency, the presence of comorbid neurologic disorders, and mental illness itself. So other risk factors include movement disorders, seizures, poor dentition, and poor eating habits. So to conclude our report, I would like to end with this saying. This information. Speech pathologists are essential service providers in mental health settings. Speech pathologists working in mental health have the capacity to enhance the health, well-being, and participation of people with mental health conditions through prevention, early detection, and treatment of communication and swallowing disorders. Thank you.